Today we're gonna talk about traumatic injuries to the anterior teeth. Okay, so let's start about the information about the lecturers for today. So let's start with the basics, the classification. Okay, so here's one by Sweets. Here's one by Rabinovich. And there's a lot. But my point is, these classifications are not used anymore because of their inadequacy. So let's talk about the ones that are commonly used today. Okay. So our focus will remain on these specific classifications which are explanatory and have stood the test of time. So let's start with Ellis and Davy in 1970. Class 1. Simple fracture of the crown involving little or no dentine. Class 2. Extensive fracture of the crown involving considerable dentine but not the pulp tissue. For the Class 3. Extensive fracture of the crown involving dentine and exposing the dental pulp. Class 4. Traumatized teeth that becomes non-vital with or without the loss of crown structure. For Class 5. Teeth are lost as a result of the trauma. For the Class 6, it is the fracture of the root with or without a loss of the crown structure. Class 7. It is the displacement of the tooth without fracture of crown or root. Okay, Class 8. It is the fracture of the whole crown and its replacement. For the Class 9, these are traumatic injuries to the primary teeth. Let's now talk about Andreassen's classification in 1981. It basically has 4 categories. And the first category is the injuries to hard dental tissues and the pulp. The first one is enamel infraction. It is the incomplete fracture or crack of the enamel without loss of tooth substance. Enamel fracture or uncomplicated crown fracture. It is a fracture with loss of tooth substance confined to enamel only. Enamel dentine fracture or uncomplicated crown fracture. It is a fracture with loss of tooth substance confined to enamel but not exposing the pulp. Complicated crown fracture. It is a fracture involving the enamel and dentine and also exposing the pulp. Uncomplicated crown root fracture. It is a fracture involving enamel, dentine, and cementum but not exposing the pulp. Complicated crown root fracture. It is a fracture involving the enamel, dentine, and cementum but exposing the pulp. Root fracture. It is a fracture involving dentine, cementum, and pulp. They can also be classified according to displacement of the coronal fragment. The second category is injuries to periodontal tissues. The first one is concussion, an injury to tooth-supporting structures without abnormal loosening or displacement of tooth but with marked reaction to percussion. Subluxation. It is an injury to the tooth-supporting structures with abnormal loosening but without displacement of tooth. Extrusive luxation or partial avulsion. It is a partial displacement of tooth out of its socket. Lateral luxation. It is the displacement of tooth in any other direction other than eggshell, accompanied by fracture of the alveolar socket. Intrusive luxation. It is the displacement of tooth into the alveolar socket accompanied by fracture of an alveolar socket. Avulsion or exarticulation. It is the complete displacement of tooth out of its socket. The third category is injuries to supporting bone. The first one is comminution of mandibular or maxillary alveolar socket. It is the crushing and compression of the alveolar socket found mostly with intrusive and lateral luxation. Fracture of maxillary or mandibular socket wall. It is a fracture confined to facial or lingual socket wall. Fracture of maxillary or mandibular alveolar process. It is a fracture involving the base of the mandible or maxilla and often the alveolar process. It may or may not involve the alveolar socket. The last and fourth category is injury to gingiva or the oral mucosa. First, laceration of gingiva or oral mucosa. It is a shallow or deep wound in the mucosa resulting from a tear, usually produced by sharp objects. Contusion of gingiva or oral mucosa. It is a bruise usually produced by impact with blunt objects and not accompanied by a break in mucosa, but usually causing submucosal hemorrhage. Last, deabrasion of gingiva or oral mucosa. It is a superficial wound produced by rubbing or scraping of mucosa, leaving a raw bleeding surface.
Emergency treatment of traumatized permanent anterior teeth in children and adolescents. Dental trauma is an emergency. Assessment and initial management should be prioritized accordingly. Telephone contact with the parents can be extremely useful in instances where the child is with a person who does not have parental responsibility. Acute treatment should be carried out to stabilize the situation and optimize tooth prognosis. We should always be prepared to provide easy-to-understand and up-to-date layperson advice regarding dental trauma. An aid memoir or script may be useful to ensure correct information is relayed with no ambiguity or misunderstanding. In a scenario where there is a confirmed avulsed permanent tooth, what do? You can either do immediate reimplantation or transport the tooth with the patient to surgery. Just lift the tooth by the crown, gently rinse with water, avoid touching the root, and immediately place in a drinking container with a screw top filled with saliva, milk, or sterile water. History taking should include the who, what, where, when, why, and how of the traumatic injury. Record as accurately as possible the time of injury. Examination. Beginning with an extraoral examination, assess and record injuries elsewhere on the body. This includes facial fractures, cuts, bruising, grazing to the head and neck, bony steps, trismus, and areas of altered sensation. The intraoral examination should include assessment of lacerations or bruising of soft tissues and whether suturing is required, teeth present, displacement injuries, hard tissue injuries, accounting for missing teeth or crown fragments, occlusion and any occlusal interference from traumatized teeth. Discernibly traumatized teeth and those adjacent to them should be assessed for presence of a sinus or associated swelling, discoloration of the tooth, mobility, tenderness to percussion, change in percussive note, response to cold testing, and response to electric pulse tester. A tabular layout enables easy interpretation and comparison of results. It aids in recording a more extensive history taking or examination and improves the clinician's confidence in collecting all necessary information. Periapical radiographs are most useful for diagnosing fractures and assessing stage of root development. Two periapical radiographs taken at different angles is used to rule out root fracture if suspected. An orthopantomogram is considered if bony injury is suspected. It is indicated if the patient's cooperation will not allow intraoral views due to age or due to discomfort from traumatic injury. Treatment planning. Early involvement with the local pediatric specialist unit is vital, especially for more complex cases or when the clinician does not feel experienced to manage or treat the patient. Contact details for the local specialist units should be available for emergencies. Management and treatment of hard tissue injuries. Enamel infraction. Infractions do not usually require active treatment. If multiple fracture lines are present, they can be sealed with acid etch and unfilled resin to prevent staining. Enamel fracture. There are 3 treatment options for enamel fracture: selective grinding of the fracture, restoration with resin composite, or reattachment of fragments if present. Selective grinding of the fracture is the simplest option but may result in an obvious asymmetry between incisors, especially in younger children with prominent mamelons. Enamel dentine fracture. Restoration should be carried out as quickly as possible to protect the pulp through exposed dentine and avoid drifting or tilting of adjacent teeth. Definitive restorations can be achieved by reattachment of fractured crown fragments or restoration with resin composite. If a definitive restoration is not possible during emergency appointment, you can place an adhesive bandage over all exposed dentine. Enamel dentine pulp fracture. Important considerations for identifying the most appropriate pulp treatment would include the size of exposure, duration of pulp exposure, and maturity of the tooth. A pulp cap can be placed on the tooth if the exposure occurred within 24 hours of trauma and if it is pinhole in size. If the exposure occurred more than 24 hours ago or is larger than a pinhole size, partial pulpotomy or pulpectomy should be carried out. Root fracture. The acute management for root fracture involves reduction of the displaced coronal fragment followed by immobilization. The repositioned tooth should be stabilized with a flexible composite and wire splint for 4 weeks up to 4 months depending on the fracture. Crown root fracture. Initial treatment for crown root fracture usually involves stabilization of the fractured coronal portion with an acid etch or composite splint to adjacent teeth and prompt referral to local specialist department for definitive treatment planning, which may include fragment removal only and resin composite restoration, fragment removal and gingivectomy then restoration, orthodontic extrusion of apical fragment and restoration, surgical extrusion of apical fragment and restoration, burial of the root, or extraction.
Now, let's talk about the management for periodontal ligament and displacement injuries. First one is a concussion. This rarely requires any intervention, but sensibility testing repeated at regular intervals to monitor the recovery of the tooth would be prudent. Subluxation. When dealing with subluxed teeth, it is important that the periapical tissues and neurovascular vessels are protected from further trauma, and these injuries should be flexibly splinted for 2 weeks, especially in mature apex teeth. Regular review with sensibility testing is required. In luxation, buccal and palatal local anesthetic should be administered before repositioning by firm digital pressure or use of forceps. The tooth should have a flexible composite and wire splint placed and a radiograph taken to verify adequate repositioning. The splint should remain in place for 4 weeks. Intrusion. The 3 treatment options for intruded teeth include monitor for spontaneous re-eruption, orthodontic extrusion, and surgical extrusion. Stage of root development is currently the best factor on which to base treatment option selection. Extrusion. A blood clot will have formed apically within the socket and repositioning is advocated as soon as possible. Local anesthetic may not be required and firm apical pressure on the crown will often reposition the tooth. Flexible splint for 2 weeks is again required. Avulsion. The practical aim of managing this kind of injury is to retain replanted teeth until full facial growth is complete. Re-implanted teeth should have a flexible composite and wire splint for 2 weeks and should be referred to a pediatric department urgently for appropriate treatment and review. Contraindications for reimplantation include patients who are immunocompromised or those who are undergoing chemotherapy or post-organ transplantation, have a significant congenital cardiac defect, and have more urgent traumatic injuries which require emergency care. Advice for follow-up dental management of avulsed teeth is to monitor regularly both clinically and radiographically, to assess for developing symptoms and to monitor the progression of the resorption, which usually occurs despite the treatment. Dental alveolar fracture. Local anesthetic is required. Fractured segment should be repositioned with firm digital pressure. The teeth should be immobilized in their re-established position by a rigid composite and wire splint using two uninjured teeth either side of the fractured segment for a period of 4 weeks. General principles for splinting include prolonged splinting periods can result in rapid root resorptions. Composite and wire splints are the gold standard. A light circular and cross-section stainless steel wire, which can be bent into the required shape, is preferable. Orthodontic brackets and arch wire can be used as long as the wire is passive. Ensure enough composite is used. Enclose any sharp edges and keep composite away from the gingival margins to aid with the oral hygiene and easier removal with sandpaper discs or composite removal burrs. Post-operative advice. Analgesia should be given at regular intervals for the first few days and may be required for longer depending on the severity of the injuries. A soft diet is observed for 2 weeks. The patient should not engage in contact sport during the acute management of the dental trauma. Chlorhexidine mouthwash can be used to aid with the oral hygiene. Parents should be encouraged to return their child to the normal toothbrushing as soon as possible. Child protection and non-accidental injury. This is a highly relevant area for the general dental practitioner, as the issue of non-accidental injury should always be carefully considered when assessing a presentation of dental trauma. Orofacial injuries are present in 50% of physical child abuse cases. The dental practitioner is ideally situated to fulfill their responsibility to their pediatric patient by early recognition of suspicious injuries and escalating their concerns to the appropriate body for further investigation.
Knowledge, awareness, and attitude among the employees in emergency ambulance services towards traumatic dental injuries. Traumatic injuries in childhood can lead to oral health problems in the future, which can cause pain and distress due to extreme psychological trauma along with compromised aesthetics. Majority of accidents in children are due to sports such as running, skating, cycling, and studies shows at least half of the children going to school, especially boys, face the possibility of some fall during play. So one of the common traumatic injuries is to avulsion. Approximately 50% of school children prior to graduation had experienced this kind of injury. 0.5 to 16% occur in permanent dentition, while 7 to 13% in primary dentition. Maxillary central incisors are now commonly involved due for both primary and permanent. Prevalence of dental traumatic injuries. 41% occur on road, or what we call road traffic accidents. In 2011, WHO projected that more than 630,000 children under the age of 15 died because of road traffic accidents. These injuries are associated with high rate of morbidity. For every person who dies, there are several thousand others who live on with various other disabilities. So what are the factors in survival and prognosis of the tooth? So one of the main factors is the viability of periodontal ligament. Immediate emergency management can help in the prognosis of an injured tooth, which helps in preserving the smile. Anderson and Bowden stated that the prognosis of an avulsed tooth is mainly determined by its reimplantation time. There is 90% success rate when a avulsed tooth is reimplanted within 30 minutes. It means that the earlier the tooth is reimplanted into the socket, the better the prognosis. Another main factor is the storage medium, which affects the viability of the periodontal ligament. Milk has been widely recommended for dentists and general population as the ideal storage medium for an avulsed tooth because it contains epithelial growth factors and has neutral pH and has little or no bacteria. The last factor is the prompt action by the employee. 30% responded that the critical time for a reimplantation to be within 20 minutes. 24% of the employees said that they will seek the dentist when a tooth is avulsed in road traffic accident patients. And 80% of the employees conveyed that they would replant the tooth into the socket if they come across any case of avulsion. So a questionnaire was designed and one-to-one interview was performed among 100 employees working in 108 emergency ambulance services in the district of Kanchipuram, Tamil Nadu. A 15 close-ended question was prepared for the assessment of knowledge and attitude of the employees towards dental trauma and its emergency management. And the results are 72% of the employees reported that they used ambulance services for dental injury, whereas 70% of the respondent staff in the ambulance said that they rarely came across dental injury when they rendered emergency helpline services. In total, 68% of them were not aware of intra and extraoral injuries during accident. Moreover, 90% of them reported that handling traumatized teeth and other structure were not included in their curriculum of first aid training. Approximately 97% of the employees with experience of less than 3 years and 76% of them with experience of more than 3 years reported that they do not routinely examine the oral cavity in a traumatized patient. So when the employees are asked, what will you do with a avulsed tooth? About 76 of the employees said that they will discard the tooth, and only 12% reported that they will ask the patient to consult with the dentist regarding the knocked out tooth. And as for the storage medium, 42% of the employees preferred water, 24% preferred oral cavity, 14% preferred saline, and 10% preferred either milk or antiseptic solution. More than 80% of the employees in the 108 ambulance services responded that they were not satisfied with their knowledge regarding traumatic dental injuries. So in conclusion, although there is lack of proper knowledge on emergency management of dental trauma among the employees, there was willingness among them to gain knowledge, as they are the first people who are approached whenever there is any emergency. An educational program that provides information and improves the awareness level pertaining to traumatic dental injuries is highly necessary to impart knowledge among the employees in the 108 emergency ambulance services.